All right, good morning. Thank you for coming. This is a big audience, so very happy to have you guys here. I have about 22 slides. I tried to cut it down from 80 or so, hopefully I'm going to be within my time slot. Some of the slides I'm going to go through relatively quickly. If you have questions, please let me know. I'm more than happy to answer any questions that you have. So the job for me today is to really give you sort of an overview of what CRPS is, like a really brief overview. Tell you maybe some of the pathophysiology behind it, and also tell you maybe some of the treatment options that might be available. This is not meant to be an all-inclusive discussion. This is not meant to be medical advice. This is just sort of an overview from the scientific standpoint, and just to give you a sort of glimpse into our mind when we see a patient and we start thinking about the multitude of options that are available and the infinite combinations that are available, just from, again, our standpoint. You just heard Gracie talk about we're one piece of that puzzle. So again, that's where the complex comes in with the C. Although I have also advocated to call that C central, but yeah, that's just me. Central regional pain syndrome. But so we could call it central. You could call it complex. You can call it chronic. But anything you call it, it's a doozy, right? I have nothing to disclose. Wasn't paid to be here today. It's my pleasure and my honor to be here today. Thank you, Jim, again for the invitation. So let's talk about how is pain defined. The official definition of pain is anything that's an unpleasant sensory or emotional experience that's associated with actual or potential tissue damage. So let's break that down into words that we can actually understand. So something that's sensory, something that you can actually feel. That can be anything from a paper cut to a broken bone, anything from a GI problem to say arthritis or nerve problems, or anything emotional. Okay, that includes things like anxiety, depression, PTSD. With actual or potential tissue damage, and that, again, that means something that that you can see, like an injury, right? Like a broken bone or skin damage, to potential. Okay, so it's really in English. I mean, that really means anything that is uncomfortable. Now, these type of experiences are very individual, and those experiences tend to form memories. When memories are formed of that experience, whether it's an actual experience or even a potential experience, the memories that are formed imprint an image in your brain. And how you respond to that image is what dictates your future with that problem, and whether it becomes chronic and how severe it becomes. It's called neuroplasticity or neuroplastic changes. Those are influenced by a variety of things. They can be influenced by cultural factors, social factors. They could be influenced by previous experiences, so how you even grew up, things that happened to you when you were a kid, coping skills, genetics, a lot of different things. Now, when we look at pain, we categorize pain into a few different categories to help us with the taxonomy. So we categorize things into acute pain and chronic pain based on the duration of the pain. It gives us an idea of how much neuroplastic changes have occurred. And we also categorize it with nociceptive and neuropathic, which essentially translates to nerve pain or non-nerve pain. So some of the more common causes of pain, things that we see very commonly. Obviously, back pain is what we see the most often. About half of all the musculoskeletal disease diagnoses involve back pain and or arthritis. And lower back pain is something that is really a burden on our society. It's the #1 cause of disability in patients under the age of 45. It's also something that accounts for over 26 million visits to doctors' offices, and about 15% of Americans say that they experience back pain for over 2 weeks. Now, why is all that important? It's important just to sort of get a framework as to how big the problem of just pain is, but also to understand that patients can have CRPS, patients can have central pain, and they can have other diagnoses. And I think that's very important, that you don't always just have one thing going on. You could have multiple different things going on. It's important to for us to try to differentiate those into different categories so we can address them individually and specifically. Types of pain, we categorize pain in 4 categories. #1 is nociceptive. Nociceptive, again, is non-nerve pain. So things like cuts or burns, those are called nociceptive pain. Neuropathic pain involves nerve injury. So things like shingles or herpes or radiculopathy, sciatic pain, those are called neuropathic pain conditions. Inflammatory pain, arthritis, things that are inflamed, and then finally central pain. That includes CRPS and fibromyalgia. Now, as you're looking at this, you could probably maybe you're thinking, well, gee, I got pain that might sort of be in a few different categories, and that's absolutely true. Okay, you can have more than one type of pain, and you can have pain that goes into different categories. So just from an interventional standpoint, what is interventional pain management? I mean, you always go to different meetings and different social events, and you meet, people who've never fortunately had any pain conditions, and they say, hey, what do you do? And I say, well, I'm an anesthesiologist and a fellowship-trained interventional pain physician. And they say, what in the world is that? They don't know what that means. And it's great that they don't know what it means. It means they've never had to utilize our services. But what does that mean? Well, that means that interventionally, with minimally invasive procedures, there's a multitude of different things that we can do. And they can range from everything from epidural steroid injections. A lot of people have heard of epidural steroid injections. What they don't know is it's not just one injection. There's about 25 different locations that you can do an epidural steroid injection. Transforaminal epidural steroid injection, a different sort of approach to it. There's about, theoretically, there's about 50 different locations you can do that. Facet medial branch block, looking at arthritis of the spine, about 60 different locations. Radiofrequency ablation, in a way of imparting longer duration relief, about 100 different locations. And then there's a variety of different joint blocks, nerve blocks, ganglion blocks, different intrathecal pumps that we can plant, although that has really fallen out of favor over the last many years. Spinal cord stimulators, which can be helpful for certain conditions. Percutaneous decompression. Those are the most common things that we do. Can you forward it? So let's talk about central sensitization. So central sensitization is a term that refers to an increased responsiveness of nociceptive receptors compared to their normal input, okay, and or an increased response of receptors to sub-threshold inputs. So what does that mean in English? That means inputs are no longer perceived correctly. They're perceived in a way that's far more amplified than they should be. Another term for this is wind-up phenomenon. When your brain is wound up, it's like it's amped up. It's like it's racing 100 miles an hour. So little inputs make it seem like it's a big deal. Okay, so we have a lot of different types of central sensitization conditions, which we'll talk about in just a minute. At least I try to categorize, when I see a patient, into two separate categories, central versus peripheral, and once we've done that, we also look at organic versus inorganic diseases. So another description of central sensitization, it's funny, this was actually described by Descartes back in 1644. So almost 500 years ago, and we're still struggling to get even the medical community to agree of whether or not central sensitization exists, which I think is horribly embarrassing. And he had described this idea that when there's an injury, there's a pathway to the brain, and the brain interprets this injury. And we actually have, incredibly solid evidence through things like functional MRI and other types of brain imaging to show that these kind of changes really do take place. This is not theoretical at all. We know exactly what kind of changes take place. We can predict what's going to happen. We can even fingerprint diseases based on functional MRI imaging. So things like CRPS appear a certain way. Things like fibromyalgia appear a certain way. When we have central sensitization, what do we see in the brain? We see patterns that are similar to memory patterns. So, we all form memories, right? And when we form memories, we see certain changes happening in the brain. When those memories then are, again, like we talked about just a few minutes ago, when those memories are interpreted by the brain and a response is created, that's when we see the pathologic process with central sensitization. So we see an excitation of a receptor called the NMDA receptor, and that plays an important role in central sensitization. We also have evidence that even perioperatively, okay, this is actually, believe it or not, one of the reasons a lot of people end up with chronic pain after a surgery. It's not just the surgery that can cause chronic pain, it's the brain's response to that surgery that causes chronic pain. There's a commercial, I don't know if, is everyone from like the Chicago area here? Or how many people from the Chicago area? A few, right? Have you heard that commercial? It's a commercial for an opiate detox program where they've got the husband and wife, and the husband's like, "Honey, where are my pain pills?" And the wife's like, "I don't know. You're still taking those?" And then he's like, "Yeah, I'm still hurting." And she's like, "I think you're addicted. It's been 2 weeks since your fusion surgery. I think you're an addict." Have you guys heard that? Anyone heard that commercial? Who's heard that? Like 3 people. I should record it and play it at these things because they should drive you nuts. They're essentially implying that someone butchers your spine and you should be totally pain-free afterwards, and if you're not, you're a drug addict. It's incredibly offensive to anyone who has any type of chronic pain. And what that commercial does is completely ignores the fact that it's not just the surgery. Even if the surgery's perfect, even if you heal perfectly, it's the brain's response to that surgery that can be pathologic. So potential mechanisms in central sensitization, the NMDA receptor, there's altered gene expression in the dorsal horn neurons, which live in the spinal cord. There's also decreased inhibition. So in addition to just amping up, the safeguards that are in place to amp things down have been turned off. So you can't turn things off anymore. Your brain doesn't know how to turn things off, and that's a problem. Microglial activation and thalamic and somatosensory cortex changes. So what are some of the types of central sensitization? You've probably seen these diseases before. Things like anxiety, chronic pain in general, CRPS, RSD, depression, fibromyalgia, headaches, opiate-induced hyperalgesia, phantom limb syndrome, and PTSD. Now, I bet a lot of you probably thought, hey, these are all independent diseases, or, yeah, I have pain and I'm depressed because I have pain. And the reality is, sure, that might be true, but the reality is that when you look at the science behind it, the pathophysiology of these diseases is actually very similar. It's your brain's inability to respond to a stimulus correctly. And it's not something that's voluntary, that's what happens, And all these diseases need to be looked at, I think, from the microscope of central disorders, central pain disorders. So how do we treat this? There are a lot of ways to treat this, and no one way is 100% successful all the time. So sometimes we need, like Gracie said, we need multiple different modalities, and some of them may give us 98, 100%, some may give us 10%. We need 10 modalities to achieve a good result. So there's some therapies that are available. Physical therapy is one of them. Mirror box therapy, where patients can help with localization of extremities. Graded motor imagery, tactile discriminatory training, and sensory discrimination training as well. Neuropsych feedback or neuropsych therapy involves EEG biofeedback. Also something called brain mapping, which I found to be very useful in some of my patients. Cognitive behavioral therapy, relaxation techniques, and hypnosis. Other treatments from a medication standpoint, and you can see these are just categories of medications. These aren't even specific medications. But, and again, this doesn't mean that everyone takes these medications. It's just that these have been used in central pain and CRPS. Alpha or beta adrenergic blocking agents, anti-inflammatories or NSAIDs, bisphosphonates, Botox, calcium regulating drugs, GABA analogs, ketamine, local anesthetics, opiates, SNRI or serotonin norepinephrine reuptake inhibitors, and vasodilators have all been used. Some interventional options that have been used for CRPS, epidural blockade, and this is not looking at epidural steroid injections, rather it's looking at epidural catheters with numbing medication that's a sort of prolonged epidural blockade, and it can last for days and in some cases even weeks. Intravenous immunoglobulin, intravenous regional sympathetic blockade, also called a beer block. Ketamine infusions, selective sympathetic nerve ganglion blocks. Some examples of that are the stellate ganglion block or lumbar sympathetic blocks. And finally, spinal cord stimulators. So I'll go over ketamine real briefly because that's really something that we found has been, in some cases, absolutely miraculous. You just see these patients walking out with 100% pain relief, right at the end of the procedure, and it can last for sometimes weeks or months at a time when literally everything else that we know has failed. Ketamine is not a new drug. It's been around for half a century. Okay, it's been around for a long time. It's used in every OR across the world on a daily basis. I mean, it's nothing new. It's just that it's something that seems to be still very misunderstood by the public and also by non-anesthesiologists, physicians who are non-anesthesiologists, who are not familiar with ketamine. So it was first synthesized by Calvin Stevens in Detroit, and it was first introduced or approved by the FDA in 1970. And it's actually considered one of the core medicines by the World Health Organization. So they actually say that this is one of the essential medications that has to be present in any healthcare system that is even remotely functional across the world. So very useful medication. It works on the NMDA receptor, which we know is one of the pathologic parts of central sensitization and of CRPS. The NMDA receptor is incredibly complex with a lot of different subreceptors, and I will not get into that today because it's just not going to resonate very well. But it's a very complex receptor, and what we found is ketamine appears to bind in over a dozen different ways to that receptor and other receptors. And that's why it's such a unique molecule and it works so well. Here's just an overview of ketamine's mechanism of action. So you can see there are well over a dozen different mechanisms of action, which makes it an incredibly complex molecule. So what are the effects of ketamine? Well, what it does is it prevents central sensitization, both in the brain and the dorsal horn neurons, by binding to NMDA and a bunch of other subreceptors. Cardiovascularly, it actually can increase heart rate, blood pressure, and cardiac output, which is what is again, very unique. Most anesthetics depress it. This one increases it. This one also can increase pulmonary function by being a stimulator to beta-adrenergic receptors. Most anesthetics depress respiratory function and make you stop breathing. This one actually can potentially stimulate respiratory blood flow and function. It's actually one of the reasons why ketamine is used in the battlefield, because when you have an injured person in the battlefield and they're losing blood, the last thing you need is to depress their cardiac output and depress their blood pressure and cause them to stop breathing. So they'll use ketamine as something that can act as a dissociative agent, something that might help with their pain a little as well, and until the patient can get helicoptered over to a facility where they can do whatever else needs to be done. Neurologically, again, it can increase cerebral blood flow and causes sensory and perceptual illusion. So that's where the hallucinations can come in. So sometimes patients will experience hallucinations or vivid dreams with ketamine, usually very short acting, usually just during the administration of the drug. Perioperatively, it's been used for years, and we found many studies to show that it actually reduces the progression of chronic pain. So it also reduces the need for opiates and pain medications right after surgery, because again, it prevents that brain from sort of misperceiving that surgery. And finally, let's see. Okay, can you advance it? And finally, with the ketamine and PTSD, we talked about the battlefield. So this has been used in veterans and soldiers often. We've actually used ketamine as well for PTSD patients. We've had some military patients. We've had some patients who have been rape victims and suffering from horrible PTSD. And we've had significant success with reversing the effects of the memories, not the memories themselves, but the paralysis that becomes from the memories themselves. And there are studies also that help support that. So what are some of the challenges of treatment and just in CRPS in general? Well, number one, and if any of you have been to any physician and have CRPS, you already know number one is lack of physician education. There still to this day isn't a med school in America that actually has pain management as a course, as part of their syllabus. Did you hear that? To this day, there isn't a medical school in America that actually has an entire course in their syllabus on pain, which is, when you think about it, all of medicine, right? I mean, why do you go to your doctor? I just gave you the definition of pain. Everything you go to for your doctor is pain, right? Even a sore throat. So when you actually flip it and you look at it from the opposite standpoint and you take the symptom and now you try to figure out the disease, shouldn't all of med school be really pain management? It should be, right? There isn't a single med school in America that has a solid, semester-long course in pain. That's a problem. So everything is still done with stereotypes. Okay, there's like, well, I heard this and I heard that, which is why if any of you have gone to the ER and said, oh my God, I'm having a CRPS flare-up, they'll say, oh, I think you're a drug addict, right? Has anyone got that? Anyone? Yeah, okay. So, yep. So that's stereotypes, right? That's kind of discrimination as far as I'm concerned. Physician egos, far be it for a patient to know more than a doctor, right? Yep, you guys have noticed that as well. Physician laziness. Now, to be fair, okay, let's defend for a second. Let's defend some of these physicians. Part of that laziness in the past was just laziness, right? I mean, oh, we take Wednesdays off to go golfing. I never did, by the way, so I can say that. But part of the laziness now is that many of these physicians are owned by big hospitals. Okay, and starting in about 10 weeks, you're going to see a significant double-digit drop-off in private practitioners because I don't know if you're aware of Medicare's changes, but Medicare no longer will have a fee-for-service model in 10 weeks. If you're not familiar with that, you should Google MACRA, and you will be, make sure you're sitting down before you read that. And so the laziness now is that they're owned by someone and they're not allowed to do anything out of their protocols. It's just basically come in, 3 minutes later, get out. Logistical issues, just treating patients. Sometimes there's a lot of logistical issues in the ability to treat from a facility standpoint, overhead standpoint, those kind of things. The complexity of the science, we haven't gone over really a lot of the science, but maybe you've at least got a little primer to see these are complex sort of science things to comprehend. And complexity of treatment. I mean, it really, like Gracie said, it requires a team of really knowledgeable people to impart good success. Lack of coverage, that's becoming an absolutely huge issue. I mean, it literally costs us more to treat someone than we get reimbursed in many situations. Like who here goes to work and pays your boss to go to work, right? I mean, that's literally the situation we're seeing. It's a horrible problem because most physicians did not go into medicine to not be able to help someone. We all went to help, and it's becoming an increasingly bad problem. And then lack of reimbursement. I have a little slide there on the side just showing you kind of documenting the challenges we go through. I had a CRPS patient who had 100% relief with ketamine infusion. She had a crush injury to her hand at work, and 100%. Just a frame of reference, she had failed 7 other physicians, and she'd been to physicians in 2 different states and failed everywhere, and we had 100% relief. Okay, that's awesome, right? You'd think that people would be happy. Well, of course, the insurance company wanted to, their goal is to cut her off, so they got a independent medical examiner who happens to be an anesthesiologist and a pain physician and the director of a residency program at one of the hospitals in the Chicago area. So this little schmuck is actually teaching the future doctors of America how to practice. And this guy actually, I have it on the right, I'll sort of just summarize it, but essentially he basically called CRPS and central sensitization, quote unquote, purely speculative. So basically, it's like saying the brain doesn't exist, because that's what it's saying. And this guy got paid to say that, and the insurance company's totally happy to say that. As far as I'm concerned, this is malpractice. I told the patient that this is not true, right? And she knows it's not true. But this is the kind of challenges we run into. So on that positive note, any questions about anything?
Yeah. Someone just asked about your acronym again, about what they should be looking at for advocacy.
In terms of physicians?
Or about the Medicare, yes.
Oh, MACRA, M-A-C-R-A. Yeah, M-A-C-R-A. So that was a law that was passed, believe it or not, it was a bipartisan law. So we can't even blame one party or the other. It was a bipartisan law that was passed about 2 years ago, and it's getting implemented as of January 1st. It hits physicians January 1st, and then it hits everyone else, including physical therapists and home health and everything, by 2019. So by 2019, every single segment of the medical world will be hit by this. And essentially, summarized into 3 categories, it's fee for value. Value is based on how much you utilize the system. The less you utilize it, the more the doctor or the hospital gets paid, whether you belong to a hospital or not. If you don't belong to a hospital, it's very difficult to meet those standards. And something called PQRS, or meaningful use, where you have to check mark all these different boxes to prove that you're actually doing a good job.
We're going to do questions later.
Sure.
Could you just speak about, yesterday you gave a great talk on established versus experimental. So many condition treatments are deemed experimental.
Yeah, when we try to do ketamine infusion, some insurance companies try to deem it as experimental. Ketamine's not experimental; it's an FDA-approved drug. So we're merely just administering an FDA-approved drug. So as far as I'm concerned, I don't find that experimental. The drug's been around for longer than most of the people in this room. So that's not experimental as far as I'm concerned. Now they may say it's off-label. We've looked at the label for ketamine, and actually, as far as I'm concerned, the way I've interpreted it's actually not off-label either. We respond to every single component of that labeling, and we have a response to every single one. So as far as I'm concerned, it's ketamine's an approved drug. It's been approved for basically half a century now. And we're administering it as per the label. So, yeah, sure.
Could you just give an estimate of what one of those infusions might cost somebody that has no insurance whatsoever?
It's variable. So, we do everything at a surgery center. So the problem with that is the surgery center separate, and so they have a fee and we have a fee. I would say that, and we do 3-hour infusions, which means that the total time that we spend is actually about 4 hours or more sometimes. Some people do 45-minute infusions. Some people have like inpatient long, 5-day infusions. It's tough to say. I mean, I would say that it depends if you do it in a surgery center or an office. It'll be cheaper in an office. I mean, right now we prefer to do surgery center because I just don't feel comfortable doing it in my office right now. If we end up investing hundreds of thousands into our office to create a pseudo surgery center, then that would be a separate thing. But then, of course, then you have to charge more to recoup that. But what I think I've seen is, yeah, I mean, if you're doing like the 1-hour ones, which I don't think work as well. I've seen people charge like $500 for that. If the longer duration ones can be $1,000, $2,000. I mean, it's just essentially you're paying for it's time, right? So time and resources. It becomes relatively costly because this is not a cure. It's a management tool, and in some cases a very good management tool, but a management tool. So like let's say you need one every 2 months. It might be 6 per year, and let's say that's $1,000 a piece. That's 6,000. Let's say it's 2,000 a piece. It's 12,000. So it starts adding up, and that's in addition to the ridiculous premiums that are now charged and the ridiculous deductibles that are charged. So, and that's just one treatment option, right? That people could be on other things. So. I think the best thing I think moving forward is insurance companies also recognize what this is and maybe have some coverage and start realizing that in the right hands and in the right settings for the right patients, it's a valuable tool and it works and the science backs it up.